So I would request you all to just unmute yourself for a while, and we will wait till some people join and we'll start our session.
আমার ল্যাপটপে এটা ঢুকবে কি? আমার ল্যাপটপে যাবে? আমার ইয়ারফোন দে।
So for time being, I'm just muting other people so that once our moderators and our speaker join, we can start our today's session.
Hello.
Good evening, sir. So for time being, only moderators and the speaker will be.
Hello. ল্যাপটপে খুলুন, ল্যাপটপে কেন হবে না? মোবাইলে ক্লিক করুন লিঙ্কটাতে, যে লিঙ্কটা দেওয়া আছে না, লিঙ্কটাতে ক্লিক করুন।
Good evening to all my teachers and my colleagues, my juniors here. We are just waiting for our speaker to join. Our moderator sir is here, Dr.Indranil sir is here, Somnath sir is here, Sabal sir is here. So good evening and greetings to all of you sir, from our side.
Good evening.
Sir.
Good evening, Shivam.
Good evening. So I have already sent the link to Debabrata sir. He will be joining in 2 minutes. He was in his hospital currently on duty. So he said he'll join in a minute or so. Meanwhile, I'm just making everybody join the meeting, and once we all are here, we can start our today's meeting. Debabrata sir is also here, and we are just waiting, sir, for Debabrata sir to join, and then we can start our proceedings. Meanwhile, I would request other than moderators to please mute yourself so it won't create disturbance and while the speakers speak. We are just waiting for people to join. So meanwhile, if we just want to cover the time till our speaker joins, if we see about this operation that we are going to talk today. So our topic of today is a critical review of hypocalcaemia in a total thyroidectomy surgery. This thyroid surgery, we all know, have gone through a phase of progression. That means through the history, if we see any surgery that we are doing today, the perfection with which we are doing it today, the credit goes to the researchers, the surgeons whose dedication and work has proved us that we are doing it with less complication, with more successful rate. So this surgery was also has a great history of its own, and if we see, the first surgery which was done in the history was done in around 952 AD. So it was Sir Albucasis, who first did a total thyroidectomy in 952. Right? So straight from the history, the first diagram, the anatomical picture was drawn by Leonardo da Vinci, and then this thyroid surgery has grown over the phases. So we know among different thyroid surgeons, two main surgeons, which are Theodor Billroth and his people, that is Theodor Kocher, right? So both of them are pioneers in field of thyroid surgery. And if we see from history, a very beautiful story which is related to our current topic is one surgeon, which was Halstead. He got an opportunity to observe these both great surgeons, which were our Billroth and Kocher. So both of them are having different types of observation. Kocher was finding cretinism in his thyroidectomy patients, and Billroth was getting tetany in his thyroidectomy patients. So once it was observed why this. So our speaker, sir, Dr. Debabrata Biswas, sir, is here. Greetings to you, sir. Good evening. You can unmute yourself, sir. Our speaker, sir, Debabrata sir, is here. Meanwhile, apart from the moderators, I would request everybody to mute themselves. We can take over whatever questions come after the session. We will ask, we will solve each of everyone's doubt, but it will be after the session. Till then, just mute yourself so that we can hear a clear voice.
Shivam, can you hear me now?
Sir, pretty clear, sir.
Thank you, thank you.
Very clear. So, sir, I was just through the history, from the history, I was telling an incident, how we got into this hypoparathyroidism and the hydrogenic removal or trauma to the parathyroid while doing thyroid surgery. So I remember once Halstead told his observation that he got a rare opportunity to observe both Billroth and Kocher. And what he told was, Billroth was getting more of a tetany patient in post-op complications, while Kocher was getting cretinism and not that common as tetany in his post-op complications. So what he delivered or made a conclusion out of his observation was, while Kocher was performing the thyroidectomy, he was doing the thyroidectomy very neatly. He was in the tissue planes, the field was very, means bloodless sort of field, and he was removing the thyroid without damaging the capsule. So it was less, means there were less incident of injuring the parathyroid and the supply to the parathyroid. While the Billroth was operating, he was more or less a fast surgeon. So he was very fast in his procedures, and what he was doing is he was not considering that tissue planes and might be injuring the parathyroid or the vascular supply of the parathyroid. So these observations have led us to now focus more over preserving and giving less complication of hypoparathyroidism in the surgery. So over the time, we have now realized that giving your patient hypoparathyroidism after a thyroid surgery is 1,000 times more grave than doing any other complication like recurrent laryngeal nerve palsy and other. Because for these, you have different manuals, different procedures by which you can correct it. But once you give your patient a hypoparathyroidism after a total thyroidectomy, it is like you are increasing the morbidity 1,000 times. So we at present we have our moderators also, our speakers are also. So I would hand over the stage to our moderator, sir, for our speaker sir's introduction.
Good evening. Let me just introduce Dr. Debabrata Biswas. He was my senior postgraduate resident in Kolkata Medical College way back in 2001, 2002. Hello, Debabrata. It's nice to see you after all these years.
Yes, definitely. Nice to see you all.
Thank you. You look the same. You have not changed at all. He did his MBBS and MS. He did his MBBS and MS from Medical College and Hospital, Kolkata, and thereafter moved to the UK to do his MRCS and FRCS over there. He is currently the consultant otolaryngologist and head and neck surgeon at the Luton and Dunstable Hospital in England, and he has focused his studies, his work on head and neck surgery and transoral laser surgery. For the last 5 years, he's been even more focused on thyroid surgery. He has over 30 publications in various journals, 26 of them as first author, and has more about 50 odd presentations. I would like to tell you more, but then that would take the whole day. So without wasting any more time, I would hand over the stage to him. He's going to speak on a critical review on the management of hypocalcaemia after total thyroidectomy. Over to Dr. Biswas.
Thank you very much. I'd like to thank Dr. Ghosh from Uttarsang Deshi group to invite me, along with Professor Shamnath Shah, who asked me to do this talk. Thank you to Professor Shah, then Moderator Dr. Mukherjee and Indranil Pal. Thank you for your kind introduction. Thanks to Shivam particularly for helping me out in the technology, which I'm not advanced at. Thank you, Shivam, for that.
Welcome.
And let's go into the screen share and get my presentation up here. Shivam,
Sure.
talk me through once again, okay?
Sure. So on the left bottom, you will see present now button.
On the left button, left.
Present now, sir.
So add groups in call screen share, yeah? Screen share.
Sure. Yes, right.
Okay. So start broadcast.
Right.
Can you see my screen?
Yes.
Yes, we can.
Okay. So can you see my presentation?
Yes, sir. Pretty clear.
Okay. Thank you. I think it's Shivam, that's the biggest screen we can get here that way. So thank you for inviting me once again to various people I have worked with. Time passes, but relationship stays with this. Now, as you understand, my initial days was in Medical College, Calcutta. I did my MS from Calcutta as well, and then I moved to UK. In the early part of my training as ENT, we call it specialty training, I focused on thyroid surgery and head and neck surgery. So that was my interest to take as my career choice for long-term plan-wise. Now we are talking about hypocalcaemia after total thyroidectomy, which is a quite difficult situation sometimes we face, and we need to have a clear plan, a blueprint. How can we take it forward? On that basis, I would like to introduce my hospital, which is Luton and Dunstable University Hospital, where I work. If you look at London, just above the London, outside London is Luton, based at where is an airport. You can see just above the London, north of it is a southern part of England. Now, it is often called my hospital L&D nationally, and Luton and Dunstable wise. It's an acute hospital. We cater for 3 different counties. As you understand, the England is divided into not districts, rather counties. So including mainly Bedfordshire, also Hertfordshire and Buckinghamshire. This is now under a joint trust, which is called Bedfordshire NHS Foundation Trust, because we have taken over the Bedford Hospital recently during the COVID period. Our patient population is 350,000. We have a 3,400 staffs, and we are the specialist center regionally for head and neck cancer, including thyroid cancer. So this is the first center. If you go north of London, this is the first center which comes in the southern part of England. As I mentioned, I focused my training and my further posting in my early part of my career when I was a specialty trainee to learn more, to develop more insight in head and neck and thyroid surgery. What is the key of thyroid surgery as compared to rest of the head and neck? For thyroid surgery, if we do things rightly, then your success is quite predictable. As compared to in a head and neck cancer, even if you have a very good operation, outcome sometimes depends on many factors. So that's the way I see thyroid surgery slightly different from head and neck. At the moment, my general work in ENT is around 10-20%. Most of the time, I do head and neck, and out of the head and neck, 1/4 is for thyroid, parathyroid work. I have a full day theatre list, 1 day clinic, and 1 day cancer-related work. So that's most of it, the work of the whole week. Now, coming back to our main topic of hypocalcaemia, to understand that I given the figures all from the UK, from this country. I'm sorry, I did not bring any figures from India or USA because I thought that is more relevant. The reason I'm telling, because NHS is completely free at the point of service or delivery. Hence, documentation is not biased in that way as compared to many other advanced countries, including USA, because they are based on a private setup, private money matters there. If I compare to Indian structure, because of the vast number and population, I think documentation is a challenge still. Hence the audit we have nationally, which is called British Association of Endocrine and Thyroid Surgeon. I have quoted most of the figures from their database for us to understand the subject better and to come to a conclusion with a better understanding, as this is my intention to finish this topic. So in this country, we do 18,000 thyroid operation. If you take two sites together, it's 29,000 operations, including revision surgery. That figure is a little bit older, but number did not increase that much, though there is a recent increase because of the investigation is too much, including PET CT scan, which pushed us to do more operation than before. What did I mean by that? Sometimes on a PET CT scan, there's a hot spot on the thyroid, and that led further investigation, and which is an incidental finding, but we cannot avoid of not doing anything. So that is one way of increasing number. At the same time, people are also going privately for scan, and they picked up some small lesion, which usually will not cause any problem for the patient, but that may increase the number of hemithyroidectomy operations. Now the operations, the number I've shown, the male-female ratio, if I go for, is a 4.5:1 overall. But if you look at the malignant ratio, is different. And I quoted the page number of the audit, which is, this is a national audit we have every few years. So malignant cases, the ratio, female-male ratio, is 2.6:1. So overall 4.5:1, but malignancy 2.6:1. Cancer in nationally is 1 in 100,000 population in male, and 3 in 100,000 population of female. So usually when we quote about the risk of any cancer or any other disease usually mention about 100,000 population. So 1 in 100,000 for male and 3 for female. That's the overall ratio for us to quote. Now in the country we have 189 surgeons, 37 surgeons usually perform 50 plus, which you may find it a very low number. I understand your operation and numbers and cases are much higher than here in the UK. But the reason I'm telling this number, that's the way you can see who are the thyroid heavy surgeons or not in their practice. So roughly 20%, 1 in 5 perform 50 plus cases a year, and only 5%, around 5% who do the surgeons who do 100 cases plus per year. There are only a few surgeons across the country who has got a very high number, like 400, 500, but there are very, very few in the whole country. So anybody who has got 100 plus cases a year, they are the proper heavily practiced in thyroid that we assume. That's given on the March 2016 figure. So given the surgeon who has got interest in head and neck thyroid, and even if I say about the ENT colleagues in Calcutta, who has got interest in thyroid and who does a pretty much a good number every year. So this topic is important for them and also for all the trainees present over here. Now, why we need to know this kind of thing? Because it helps you to improve your blind spot. What did I mean by that? When you drive a car, you know there is a few blind spots. This car is going ahead. So there will be some kind of blind spot always there. And important thing for you to understand, there is a blind spot and you can avoid it with viewing mirrors, etc. and your understanding. But the problem, if you do not know there is a blind spot, in other way, if we rephrase the sentence, if you do not know what you do not know, then is a problem for thyroid surgery. So that leads to that Johori's window model that comes from my background of medical educations. So that comes in a situation when you do not know what you do not know. We like to reduce that box in that model, and that will help us to decrease our complications overall. Hence, in this topic, in this presentation, I would like to come into details of the hypocalcaemia and the problems entails with it, try to define the problem, trying to find what is the best way of dealing with the problem, and then we'll come to a plan how we can control this patient as a long term. I'd like to come to a new publications. What is the gap in the literature? Is there any controversy anywhere? And end with a blueprint to go home with. I will not discuss in details about the physiology or in details about acute management, medical management related to hypocalcaemia. Rather, I will focus on the long-term plan, which is less discussed, or there is no clear-cut guideline across the world. So far, is it clear? You can hear me clearly, right?
Yes. Voice is
Good.
clear.
Okay, I'll carry on. Okay, you stop me anytime if you need a break, or if you need to clarify any points, or you can give it to Shivam and we can discuss at the later point. At this stage, I would like to have, before I come to the main subtopic, I'm on call today, so in case there is a life-threatening emergency, I have to leave this presentation. Or if there's a fire drill somewhere today, which I'm not expecting either of them, I've got senior registrar with me, so he should be able to control the most of the things. So these two are home or housekeeping. I will apologize if something happens like that. I'm sorry. Now, coming to the main topic, the cases of total thyroidectomy. I also like to ask the senior colleagues, what is your indications of total thyroidectomy in Calcutta at the moment? For me, there are basically three as I operate. I given the figures of national figures. I did not give my own figure. My number of thyroid parathyroid cases around 100. So I am one of the 5% heavy thyroid surgeon in this country, the practice-wise. Now, in my practice, this is not for any journal, so you get a list of indication, but in my practice, the commonest indication for total thyroidectomy is a cancer. That means either you get a Thigh 5, you go for straight away total thyroidectomy, or say Thigh 3F or Thigh 4. Then you have a diagnostic in the first stage. Then if this is a proven cancer, then a total or completion thyroidectomy at the second stage. That is the commonest indication in my practice. The second common is the pressure symptoms. Someone has got a goiter, long-term goiter, but has got some pressure symptom, either breathing, or swallow, or change of voice, or trachea pushed one side, or some retrosternal extension to it. And then we have to sometimes consider total thyroidectomy, particularly if the patients are young. I'll get to the point when I discuss with you to know your experience. If the patients are old, then we may consider about hemithyroidectomy instead of total thyroidectomy. Because if someone is, say, 8 years old, no point of putting those patients to a high risk of going for total thyroidectomy. Rather, take the bulky bit out and relieve the symptoms and give a better quality of life. If the patients are young, if both sides are involved with the goiter, if we do not go for total thyroidectomy, this patient will come back in 10 years, 20 years down the line for completion, highly likely. Then the operation will be more difficult. That is understanding in our practice. The least common is the toxicosis. Some patients are very hypertoxic, or in other sense, who required a very high dose of thyroid replacement, and endocrinologist could not control the dose of it. So sometimes those are the indication. Rather, is a fewer indication or less important in my practice. So these are the main three. There's a list you can find in the books, but this is a common thing. Can I ask my senior colleagues over there? So what is your practice? So if you can give me some of the few of yours, please.
Anyone who wants to speak can unmute him or herself.
Yes, anyone, please? Well, I would like to put in a word over here that we see very few cases of pressure symptoms, except when the thyroid goes intrathoracic. Otherwise, I have seen very few cases with pressure symptoms. The main indication is cancer, hypothyroidism too. I would like to know the opinion of other colleagues. How many of them have seen pressure symptoms with benign thyroid disease?
Professor Shah, do you want to add anything? Dr. Mukherjee? Dr.
Anyone, please? Dr. Mishra, Dr. Shivaam Mishra, any inputs from your side? Dr. Karmakar?
Somnath sir, you have to unmute yourself. Yours is muted.
Yes, Dr. Shah, can we have some input from you?
So please unmute yourself. Yes.
Yes, you are unmuted now.
Cancer is the main indication here. And we do get cases of the hypothyroidism in the most of the cases, because the number of the cancer in India are quite high and number of thyroid cancers are quite high. We do not get much cases of the patients symptoms, particularly what he wrote it in the young patients, where he is doing the total thyroidectomy. So we'd like to clarify this point, that future symptoms in young patients in total thyroidectomy.
Thank you.
Okay, then we'll continue.
Okay, thank you. This is just a comfort break. Just make sure that everyone is listening. Now the next part is coming to the complication part of it. We know the practice varies, but we have to go for completion of total thyroidectomy time to time. Then when you do that as a trainee, when you observe or you've done the cases and you face with some complications. So before I give my list of complications and the commonest in this country and in my practice, same thing I like to ask my audience, my colleagues, my peers. In your practice, what is the most common complication? I said most common complication. Please unmute yourself and talk. If there's trainees and fellows there, please talk. Then we can understand each other better. So I said most common complications. Unmute yourself. Yeah.
Sir, if I speak on my experience as resident during my residency days, so it depended upon who is operating. So if a resident, a PGT trainee is operating, what we saw is the most common complication is the patient change of voice due to somewhere either paresis or paralysis of recurrent laryngitis. The immediate one that we saw.
Yep, absolutely true. This is thought to be most common complication. Any other senior people would like to change that opinion?
Well, if we are talking about hemithyroidectomy, then probably recurrent laryngeal nerve paralysis is the most common complication. But if you're talking about total thyroidectomy, I think hypocalcaemia is much more common than a recurrent laryngeal nerve injury. However, the majority of the cases of hypocalcaemia that we have got are transient. They do not last for too long.
Correct. Any other opinion from the audience?
You can unmute yourself and speak.
The commonest complication in my hands over these years has been recurrent nerve palsy. Hypocalcaemia, in a few cases, it's more transient than a permanent and a very grave one.
The voice is very feeble, sir.
Voice is feeble, but still I can hear this. Okay. So do you use a nerve monitor for each case of thyroid operation, or you don't?
Oh, never. I don't use personally, and I don't know anyone over here who uses nerve monitor. Almost all of us rely on the knowledge of anatomy of the thyroid and the recurrent laryngeal nerve.
So that's a big difference between your practice and here. I won't do any thyroid cases without nerve monitor. This is one way it's not good for patients, and from the legal viewpoint also, in this country, if someone have a nerve injury and both, then it is slightly difficult to defend if you have a nerve monitor in your hospital and you didn't use it. Did you get my point? So if that's the practice evolves throughout the country, the very few number of surgeons right now do thyroid surgery without nerve monitor. So I think that helps us to reduce the number of recurrent efforts. Now, I like to give you the figure of what you can see across the country. You can unmute yourself and I'll carry on, please. Now, the number 1,800 cases I've given you, this is a figure coming from that big audit. So this is absolutely solid figure. It's a dependable figure and you can quote that anywhere, even if you're consenting time. However, you should quote your own figure. That will be the best practice. So for total thyroidectomy, the commonest complication is hypocalcaemia. And it can happen in 1 in 4 cases. So sometimes you may not find it because you didn't, if you do not do the calcium check, or is a patient's been discharged before having calcium check. But if you have a meticulous calcium checkup, between transient and permanent, together is can be as high as 1 in 5. As compared to recurrent laryngeal palsy is only 2.3%. And in the recent publications from the BATS, or British Association of Thyroid, is on only 1.2%. So you can see it's coming down every year. The figures on the green is a most recent publication. Figures on the red is 2-3 years ago, but they are quite comparable. I given the both figures for you to see what happens with time as well. Now, if you're talking about voice change, that including superior laryngeal and other factors, for example, if you release a long-term pressure symptoms, that also can cause a change of voice as perceived by the patient, but not actually any recurrent laryngeal nerve weakness. So that is around 8-9%. So together you can get as high as 8-9% of voice change, that including 1.2% of recurrent laryngeal, which is very low. In a simple word, if I have a nerve injury, I have to do another 70-80 cases without nerve injury to get my figure right. So it's quite strict. It's very important. Now, if we talking about, because you one of you mentioned about lobectomy, the figures for the lobectomy from nerve injuries on your right column, you can see is 1.8%, or in the recent figure is 1%. It's coming down. Lobectomy is only just 1%. You can quote. There's a few other different complications, including complication of hematoma, tracheal injury, guide leak, thyroid storm. That can be discussed in other day. But today we're going to focus on the hypocalcaemia. The reason I've given this figure for you to understand, this is the main issue. This is the main thing for thyroid surgery: how to control, how to prevent, how to understand, how to predict that patient may have hypocalcaemia. I'll come each and every point with my slides. Now, as I mentioned, I'm not going to go in details of the pathophysiology of calcium hemostasis in our body, but as you understand, is a broad figure. Parathyroid is the center who controls the calcium level in our body instantly. So in this case, after having total thyroidectomy, the two things happens. Your thyroid gland completely goes, and along with, we have a slight doubtful of a parathyroid glands. Why I'm saying that? Because the operation has got two key steps. One is to identify recurrent laryngeal nerve with your anatomical knowledge, then identify the 4 parathyroid glands if possible, if not at least 2 of them. And as you know, the superior one is a much more constant in location as compared to inferior one because of the embryological variation. So once you find the nerve and you secure the nerve, the next focus immediately should be on the superior parathyroid gland. At least if you secure 2 superior parathyroid, in my opinion, we are safe. When there is a parathyroid failure happens, then it can be for different reasons. Most commonly, we did not see those glands clearly, and we removed those glands along with the thyroid. If there's a big thyroid, that can happen quite often. Or even if we saw them, we did not preserve them carefully. What do they mean by them? Because of the poor tissue handling, or we didn't look into the vascular supply of those glands. So even if we kept, as we thought, is a parathyroid tissue, they did not work. They may not work after operation because of the lack of vascular supply. Most likely they are transient because they may get some collateral supplies, or the vascular channels which we left behind, they'll open up with time and supply the glands, and you get a quick recovery of the thyroid function, parathyroid function. Come to the point how you can predict that, how you can define that in a minute. The common 4 causes of parathyroid failure when you're talking about the iatrogenic causes. I would like to mention here another situation where you may have to sacrifice parathyroid gland when there is a cancer with a metastasis, multiple metastasis in a central compartment. I had few patients like that, and where it is very difficult to decide whether this is a metastatic lymph gland or is a parathyroid gland. Now, one option, you can take it and you can do a water test. That means you float in the water, but it's not going to be helpful because both lymph gland and the parathyroid both will sink, so it will not helpful. I'm talking about if you like to reinsert within a sternomastoid muscle again. So this is another complicated situation which I face few times, to differentiate between the parathyroid gland and the metastatic lymph nodes, where you have to sacrifice sometimes parathyroid glands, which may lead to parathyroid failure. So how to know that? Usually I go for histological specimen details, and I look for the specimen once again to make sure that I'm not leaving behind any parathyroid gland on the specimen. If so, I take them off and reinsert in a pocket in a sternomastoid muscle. Now, as I'm coming to close to the point of the hypocalcemia, we need to know the normal figures. Different countries have got different units they use. In the UK, we use millimole for calcium and p-mole or picomole for parathyroid hormone level estimation. At this point, I'd like to mention calcium is, of course, the commonest thing we measure. But in my opinion, I'll prove you why, I'll show you why. Without knowing the parathyroid, only knowing calcium is not any use. So that could be a change in your practice if you don't do that. Now, the calcium normal level, as we measure in the UK, is 2.2 to 2.6 millimole per liter, and the parathyroid 1.6 to 6.9 picomole per liter. So these are the baseline of our discussion today. Then we will go through one after one. What is the problem here? We know that hypocalcemia, as I showed in my recent British thyroid audit, can happen in 1 in 4 cases. So it's quite high, actually. The same thing's been seen in a Athens-based paper by Demetrius, published in 2026 in the International Journal of Endocrinology, given the exact same figure. They have got 10 years, 1 center prospective follow-up of 281 patients. and they're given the same figure is 24.9% of the hypocalcemia rate. So though our audit, which has got 18,000 cases, so we have a much stronger percentage to quote, and we're quoting as 1 in 4 cases can develop hypocalcemia, either temporary or permanent. Now, the second problem in hypocalcemia after total thyroidectomy, there is no way we can define it is as only hypocalcemia or is a parathyroid failure or is a syndrome. There is no clear definition across the world at the moment, which I'm trying to bring on new literature and try to define that issue altogether. So clearly there's a lack of definition, inadequate follow-ups, and conflict of interest of reporting individual patient series. What do I mean by that? If you have a poor outcome in your practice, you won't necessarily publish that because it will show that you're a bad surgeon, particularly if you're practicing privately. So there is a conflict of interest. We do not get the higher figure, but in a proper prospective study and our audit showed some good figures, as I mentioned before. So there is a need of defining this parathyroid failure after total thyroidectomy. That is why Professor Mehena, if you heard of his name, John Watkinson, he's a big thyroid surgeon, and Ashok Shah from Sloan Kettering, they looked into a different publication across the world, and they published in 2010, a few years ago, and they have reported there's a wild variation, that means huge variation of reporting rate of hypocalcemia from 0% to 46%. So there is no consistency at all in this matter. So there is need of defining that properly. There is need to have 1/3 of the biochemically this patient to know who will get better with this clear definition. Now, the variation of the hypocalcemia also complicated by factor of quality of data capture. I feel that is problem for every country, but our data capturing is a mandatory for all thyroid surgeons, as it has to go in the thyroid database nationally. I hope that I expect that is a problem in India, in Calcutta as well now for data capture. Operative skill variation, also a problem. If someone does 25 thyroid cases a year, or someone does 100 cases a year, the skill set will be different. Now, third factor is the indication of surgery, the case mix. Complication happens less with the thyroid cancer cases than the benign cases, and I will show you the figure in a minute. And if something happens, hypocalcemia, and there is clearly very few department has got clear policy how to come out from those supplements and what will be the long-term strategy. I'm absolutely telling for surety there is a lack of policies across the world. Only big centers, they have some guidelines, and I will bring those guidelines for your attention in a minute. Based on that background of a variation of the practice, I'd like to mention that there's a need to define this problem. Shivam, I can see part of my slide is cut off. That will be a problem for you to see. Is it right? Same thing for you?
Yes, sir. Same here.
So should I go to a smaller slide version? Will be easier.
Fine, sir. Fine.
Okay, give me a second. Sorry for the interruption. Okay. Basically, this is because I'm presenting from iPad, and there is some changes. Okay, so we've been through that. Are you following me so far? You okay? You can hear me?
Yes, sir. Totally fine, sir. Totally great.
Okay. I'm sorry, now I'm coming to a slightly smaller screen because I felt like the lower part of the screen was cut off. It'll be difficult for you to follow otherwise. Now, this is one of the most important slides. The early hypocalcemia, how to define. I mentioned about the normal calcium figure. Now, if anything, any calcium level at any point, which is that we call it corrected calcium level, is less than 2.1 millimole per liter on the day after surgery, is called early hypocalcemia. There is no clear definition about how many hours after. It doesn't matter. Anytime after surgery, if the calcium level goes below 2.1, we can call it early hypocalcemia. And which is, I showed a 24.9% in a BTS figure from the last audit. What is called protected, there's different term, it's called protected hypocalcemia. So it is defined as if the subnormal intraoperative PTH or the post-operative PTH needed supplement, which is either calcium or vitamin D supplement, and which is need to be continued for 4 to 2 weeks. That means this is not only transient hypocalcemia, which is slightly prolonged. The medical term given by the endocrinologist called protected hypocalcemia, or slightly longer term hypocalcemia. This is defined by Lorenzo Poch, is an eminent endocrinologist from University of London. This paper was published in a Glandular Surgery in 2015. I will quote her name many times in this presentation. And other definitions given also, if the parathyroid hormone level goes below 13 pg per milliliter, did not work properly, definitely not. Now, when you call it permanent, there are a group of patients who require lifelong calcium supplement. I had patient like this also, particularly the thyroid patient with multiple lymph gland metastasis. If the requirement required for more than 1 year, you can call it permanent. That means there's very little chance of success of recovering the function of parathyroid glands. That is defined by Randolph, who is a big thyroid surgeon from USA. This is also redefined a similar way on the basis of the calcium supplement for more than 1 year by Granger, published in the European Journal of Oncology. At the level of the PTH also is redefined if the PTH level is 1.1 p-mole per liter, which is more or less practiced in the UK, and required calcium supplement for more than 1 year. Again, there's a very little chance of success here, and we can call it permanent. And then it's this definition again given by Lorenzo Poch, endocrinology colleagues from UCL. This is published in 2015. So now you can see it's a different way to look at hypocalcemia, a slightly different way. Then if we understand the different way of classifying this hypocalcemia, then we can tackle each problem separately, differently. hypocalcemia after total thyroidectomy has got 4 definite risk factors as we found from our thyroid audit. I mentioned before, cancer is not the commonest cause of hypocalcemia, rather other factors. The 4 important factors are children, pediatric cases, female patients, Graves' disease, and if you have to dissect, level 6 as a part of the thyroid cancer surgery. So these are the 4 definitive risk factors for developing hypocalcemia after total thyroidectomy. To give you some figures, why are those important, I will redefine it. After having first time total thyroidectomy, chances is 27.4%. If you have a redo surgery, chance is 29%. What is the 2 different? If we have a total thyroidectomy, say a patient had a Thigh 5, then chance is slightly lower than if you have a completion surgery. And if the matter goes with the multiple limb gland metastasis, the risk of the hypocalcemia is much, much higher, which is 36.9%. So this is the highest risk of developing hypocalcemia of level 6, proper level 6 dissection. Then the other figure comes as a 26.3% for Graves' disease. These are the medical side of it. Because of the hungry bone syndrome, the bones start calcium that gives the early hypocalcemic state. For the cancer group, if you look at, I mentioned the simple papillary cancer or other common cancer of the develops less hypocalcemia, is only 17%. Multinodular goiter, it's also 21%, which is less than what we mentioned about Graves' disease or level 6 dissection or the children. Knowing this figure, so already we have some idea how we can predict hypocalcemia which can happen to your patient. So now the question comes, which is the more important, clinically important for you, how we can predict that hypocalcemia. That based on the analysis of 115 observational studies, not cases, studies. They're given some predictors, and that's been done by someone called Mr. Bala, the senior author. You can see the publication in BGS, British Journal of Surgery. He's one of the endocrine surgeon. He's not ENT, he's a general surgeon, but endocrine practice. So he had published that as a part of their master's, PhD with the student. And based on 115 observational studies. So independent predictors are preoperative calcium. So these are the different, what I've said in the last slide. If the patient preoperative calcium is low beforehand, the chance of developing calcium is high. Hence, there is a need of knowing the baseline calcium before starting. Then calcium can be low for the different factors, including vitamin D, etc. Perioperative parathyroid hormone level. I'll come to that point in a minute. Preoperative dehydroxy vitamin D and post-operative magnesium. These are the independent predictor. These are the variables which can influence your hypocalcemia rates after operation. The clinical predictor they have given is a recurrent goiter. So I mentioned about doing total thyroidectomy for younger patients and the hemithyroidectomy for older patient for the pressure symptoms, which is one of the common, a second common indication for surgery here. So if someone had a thyroid surgery, say 10 years ago, 20 years ago, by a different surgeon, now you're going for total thyroidectomy. So I mean the recurrent goiter operation or reoperation. then the chance of having hypocalcemia is much higher, because we do not know what happened before, whether these other surgeons preserved the other side parathyroid gland, which is highly unlikely, and we are in the slightly difficult territory. Reoperation for bleeding, say for example hematoma, when it's we have to do it very harshly, acutely, then chances of developing hypocalcemia is slightly higher. Now, what are the predictor for the transient or early hypocalcemia? Inadvertent PTG excision. So we have removed actually parathyroid gland. Yes, we know that very well. Even if you auto-transplant, and which is not done properly, or it takes time for that parathyroid gland to get the blood supply, say for example from within sternocleidomastoid muscle, patient with a Graves' disease is a very, very high risk, and the female patients we know. This particular series did not mention much about the children, but we know also from the national audit that the pediatric thyroidectomy also higher rate of hypocalcemia. Now, permanent hypocalcemia, which is a most important thing. If the calcium levels, how are you going to predict that? Is anything we can predict to help us to understand and to get prepared to be more careful during surgery? So, calcium level lower than 1.88 pmol per liter 24 hours after surgery is a very poor risk. That means it's a poor predictor of having a normal calcium afterwards. Identification fewer than 2 parathyroid gland surgery. I mentioned that at least, of course, you'll try to preserve all 4 parathyroid glands, but at least 2. So if the identification is less than 2 in this series, and they have published the chance of hypocalcemia as a long term is very high. Reoperation for bleeding, I mean the acute second operation as a emergency, Graves' disease, and if the and this is very interesting, if there's a big thyroid, I mean the heavier thyroid specimen, bigger the specimen, more chance of developing long-term hypocalcemia. This is a few interesting figures coming up from this big series, big publication from Mr. We call him Bala, Professor Bala Subramaniam. He's an Indian chap. He's based in Sheffield, and is published very recently. Now, are the predicting factors developed by the Korean chap? If you know the Kim and Kim group, Mr. Park, they also have a predictor score, quite complicated. How many parathyroid you have taken, from where you have taken, is the blood supply, etc., etc. They have a quite complicated plotting. You can plot those things, and that will give you an exact figure of prediction of hypocalcemia after surgery, which is the bottom of this slide. You can see Kim et al. Published in 2017. To be honest, this is a rarely in practice in the UK. I do not know anyone who does those things in their day-to-day practice. Now, from this last few slides was quite complicated to understand the different types of hypocalcemia can develop, how we can predict beforehand. Now for the present day practice, current day practice for all the trainees, fellows, and for us, hypocalcemia can present in 3 different ways: acutely, immediately on the day or the night of the surgery, or slightly delayed. Initial calcium level was normal, but later on, second, third test, the calcium level was falling because of the poor calcium reserve and parathyroid failure. And third problem we face as a long term, as you mentioned, is a permanent. Some patients required lifelong lifelong calcium replacement. Now we define, we examine each and every situation differently. I'm not going to give much time on the acute because this is usually manual for your SHO. We call it SHO Junior Colleague Survival Guide, how to manage the acute hypocalcemia. This is a pass-fail for MS-ENT or FRCS if you do not know that. So I'm not going to go in details of this basic management. Before we come to that point, again, to remind ourselves the way we see it, the calcium is 2.2 to 2.6 normal figure, parathyroid hormone 1.6 to 6.9. First one is a millimole per liter, and the second one is a picomole per liter. Now, this is the British national guideline to control, to manage the acute hypocalcemia or any hypocalcemia issue immediately after operation. As you understand, my talk will not be based on that acute the management, but rather long-term management, which will come in next few slides. This particular chart begins with the central, you can see the central box where you measure the calcium level. Usually in our practice, hours after operation, that practice differs. Usually the morning after operation, or if you do the operations in the early morning, then it's a 12 hours after operation. My practice also is different than this, and I tell you why in a minute. If the calcium level is more than 2.1 is no problem. As you can see, the upper part of the slide. Now the lower part, where you can call it a hypercalcemia, can be three different ways they can present. Either is acute symptoms develop, the tetany, etc., as Shivaam mentioned in his early introduction. But fortunately, I've never seen those presentation. It highly unlikely happens in this country. The calcium level falls below 1.8, which is a red alarm. The second type of second group is 1.8 to 2, which is a middle group where you can. The first group we have to give IV supplement, followed by oral. Second group you will give oral supplement, and the third group where the possibly some symptoms, vague symptoms rather, and vague symptoms rather, and which may not need any treatment at all. I'm not coming into that much details of the acute management. Rather, I'll go into the long-term plan. Reason of this long-term plan, based on this paper, which is again, you can see the same author, Laurent Pulch et al. This published in 2015. The key moments when the hypocalcemia happens, either transient or long run, if we put all patients, that means 1 in 4 patients which can develop hypocalcemia. If you look into all patients prospectively, 2/3 of the hypocalcemia recovers by 1 month. That is a proper research, and we can say for surety that 2/3 of the patient recovers within 1 month. Hence, we need to have some planning. What we need to do after 1 month or 6 weeks, if it's your practice. Most of the places, particularly within our NHS, patients continue with a calcium supplement after that because we do not take chance, or it goes back to their own doctors, and then nobody actually looked into the calcium and PTH levels separately. At this point, we need to stop the management of calcium supplement, except if the PTH is lower than 13 picogram per liter. Then we have to restart surgery. So you need to stop it, then check parathyroid hormone and calcium. If the PTH is low, then you need to restart. If not low, then we do not need to start again. And again, in this particular strategy, chance of recovery is 75%. That means 1 in 4 patients, we may need to restart the calcium level. Hence, that management of this particular point need to be very tight. What do I mean by that? If patient stops taking calcium supplement, they may develop acute hypocalcemia. The chance is 25%. Hence, we need to have a tight plan for that. So, in this country, and across many hospitals, there is no definite guideline when to stop supplement, particularly. If you stop, how to stop? If we continue, how much to give those supplements and what to give? I'm pretty sure if you go back to your own practice and if I speak to each of you, you'll have a separate and different practice for each practitioners there in Calcutta as well. Now, coming to a consensus view, if the post-operative parathyroid level, I told you a few slides ago that doing calcium on its own has got very little value to predict and to understand the hypocalcemia or calcium level or calcium status of the patient after total thyroidectomy. So please do parathyroid along with calcium. So post-operative parathyroid level greater than 1.6 mmol per liter, that unit is what we use in this country, then that group of patient has got very low risk of developing post-operative hypocalcemia. So, again, I stress on the figure, if we do calcium and PTH, if the calcium is still normal but PTH low, you have a different strategy. If the PTH is more than 1.6, you can relax. That is very low chance of developing hypocalcemia. That will help you to discharge your patient home earlier than you predicted. This figure based on a group of publications are given on the at the bottom of the slide. Publications from different parts of the world, from USA, from UK, and European publications. One from Korean, China side as well. So this figure of 1.6 mmol per liter is quite important to understand here. Across the world now, there's only one country has got a definite guideline how to measure this PTH, when to measure this PTH, and what is their predictive value, etc. That is an Australian guideline. Is guideline called AE SO 6/01. If you look into any countries, this is the only country has got some sort of clear guidelines, depends on the PTH level. And they mention that if we can do PTH that can accurately predict a normal calcemic status after total thyroidectomy, and they measure at 4 hours, or they told us they prefers 4 hours post-operatively. And this is my practice as well. I do post 4 hours after surgery. Patients with PTH in the normal range can safely discharge on the first post-operative day. So this is a big change of practice. If you can manage to remove the drain early, if the calcium PTH level is normal, you can discharge the patient home. If you did not do PTH level, if you did only calcium level, and the calcium level of normal, if you discharge those patients home, they may come back with an acute hypocalcemic state. because of the low PTH, which we did not detect or we did not test. So this is a very important point to understand. In this situation, depending on 4 hours post-operative parathyroid hormone measurement, we can come to 2 different situations here. I mentioned before 1.6 ppmol is quite safe level, but the clinical governance viewpoint and patient safety viewpoint, we even increased that 1.6 bar to 2 pmol per liter. So I mentioned before on the 4 or 5 publications suggested 1.6 pmol per liter post-operative PTH is quite good enough to predict this patient will not develop hypocalcemia. But to improve that safety margin, that level even improved or increased to 2. And this particular strategy is practiced in 2 big thyroid centers in our country. And that based on a publication in 2007. Now, if the level of PTH or parathyroid hormone is less than 2, we can start oral supplement, and then we can recheck the calcium. If the level is more than 2 PTH, I'm talking about irrespective of calcium, there is no need of any supplement. We can recheck our corrected calcium. So this is a pivotal point for us to understand how that can change our practice based on PTH, not on calcium. And it's very reliable because sensitivity, specificity, and positive predictive value of the normal post-operative parathyroid level is a very strong predictor to have a normal calcium level after operation as a long term. As you can see, the figures are very high. The low PTH, in other way, this is important for the statistics to understand. The low PTH, in other way, is not a good predictor. If you have a high PTH, is a very good predictor, but the low PTH is not is a poor predictor for hypocalcemia. What I meant by that, you may have a low PTH immediately after operation, which may improve within a few days. The gland which is taken out may not work immediately because of the lack of vascular supply. As the vascular supply gets improved and the PTH level get better. So low PTH does not mean patient will develop low calcium for long term. Overall, sensitivity, specificity, and positive predictive values for this particular model is around 70%. Hence, we need to look into a bit more in details. Now, if we add PTH along with the calcium level, that probably give you a better model for prediction. That's based on the publication in 2008, where they predicted the best sensitivity is 97.9% with the post-operative PTH, ionized PTH, and the best specificity of the calcium level is 96.1%. Hence, if we can combine calcium figure and the post-operative PTH figure, we can get a much higher predictive value, which is 99% and 86%, the negative and positive predictive values respectively. So that is my final model I'm going to present in my next slide, how we can combine calcium and PTH together to get a solid model which can predict and where we can understand which patient will need a long-term plan for hypocalcemia or not. So now, putting these 2 things together, PTH and calcium, we can only come to these 4 different categories. I think this is this kind of slide, this kind of a model is completely new, and which we came up with the PTH and calcium together. Only we can come with the four different situations where either you have got low PTH, which I mentioned as low, less than 2 p-mol per liter, and the low calcium. And this patient will need definitely alpha-calcidol and Sandocal or calcium supplement. If the patient can have a low PTH but normal calcium, that has got a different strategy. So left bottom the box, then you have alpha-calcidol only once a day with a Sandocal, which is we call calcium supplement, 1 gram, 3 times a day. So the dose is slightly less of the alpha-calcidol for that group. Now the right-hand side, upper box, in this situation you have got normal PTH, more than 2. However, you have got low calcium. So it's a third situation where you need to give only Sandocal, 1 gram per only calcium supplement. No, you don't need to give any alpha-calcidol. If the PTH is more than 2 and calcium is more than 2.1, you do not need any supplement, so you can discharge patient home, irrespective of the fact the patient may develop early hypocalcemia initially, but still you do not need any supplement at all to send those patients home. In this model, it's very important, this slide, I think it's the most important slide of the whole talk. If we combine PTH and calcium level after post-operative levels, we only can end up with this 4 different situations, and you have a different strategy how to plan those patients of the calcium supplement as a long term. All this group of patients, this cohort of patients who are on the supplement, it usually reviewed by us within a week. Not by myself, I mean the consultant level, but anyone, could be a specialist nurse or junior doctors, they're reviewed by them, anyone who on supplement, for rechecking of the levels. And those patients usually seen by us between 2 to 3 weeks after surgery, because we need to give them the histology result, etc. Any newly developed symptoms on this group can attend our accident emergency department. They can have an urgent blood level, PTH, etc. So they will. So one box, this out of these 4 groups, one box can go into a different box or different group of patients overnight with the new symptoms and the change of calcium PTH level. But overtly, whatever the result you can have, we can classify in the 4 groups, and you can plan your next supplement for those patients before discharge. That is the important point to mention. This is not clarified in major textbooks based on the current knowledge. Now, what we do on the day 5, as I mentioned, patient usually comes back within a week. So we always measure the PTH calcium once again. If the PTH calcium is normal, they can go home if they are symptomatic. If the adjusted calcium is below 2.1, again it's low, or above 2.6, the juniors can discuss with that regarding supplement, and we can have a plan of action. If they are symptomatic, this is now a changing scenario. Within a week, the patient are symptomatic who were not symptomatic before. As I mentioned, the hypocalcemia may develop later on, not immediately after operation. Those patients who came to see us, our juniors, within a week, they will wait for the result, and because they may need admission for IV supplement, or they may need change of medication to increase the dose of it. Most of the patients who are symptomatic, we do not discharge them. Most of the patients, they definitely need a senior review, further checking, and overnight observation with supplement. This is only for the patient safety. Now, if we start those supplement, as we found out from that box, the 4 different situations, 4 different boxes you can put your patients. If we start your supplement, those cohorts of patients are seen in the day 5 or day 7 by the juniors, then what will be your strategy as a senior thyroid surgeon or thyroid surgeon, how are you going to control that? You're not going to continue with the management of supplement forever. And I showed earlier with the same endocrinologist Loranto and Poch, and also Sarah and Stiges, two different publications, very recent, 2015, 2016, that 2/3 of the hypocalcemia recovers in a 1 month. So two different, the chart, the diagram on the right, it shows the low PTH, which goes better, and then the undetectable ionized PTH also get better, and the median time is 1 month. Hence, if you look into details, that medical management can be stopped in a month's time and challenge the situation, repeat the PTH calcium, and you can re-stratify your patient's grouping. Again, I mentioned before, the chance of recovery of this stopping the calcium supplement in a month's time is around 75% success. What does it mean? If we stop the supplement, you may need to start supplement once again in 1 in 4 patients, i.e. 1 in 4 patients may need a longer term treatment. So this is a change of practice. Most of us currently continue with the medication forever, say 6 months easily. But this is a new way of looking at the picture. If we challenge this situation after 1 month, after stopping those figures, and that also can give you a different scenario. You may have a normal PTH or a low PTH, which may lead to something called protracted, which I mentioned in the definition, who are continued for more than 6 weeks, and those patients needs longer term supplement, and those patients which needs longer term follow-up as well. So that this particular figure, based on the Loranto Poch, based on the model that we should stop the supplement after a month and challenge the calcium homeostasis system in the body of the patient, recheck the calcium PTH, and re-stratify your management plan. And the risk here is 1 in 4 patients may develop hypocalcemia. You need to be careful about that. And those patients, we need to restart the supplement. They have put those figures after 1 month and 6 weeks, and that shows the predictive value is quite high on this model, which leads to success. I think it would be a good read for you guys to look for that paper, Loranto Poch et al., British Journal of Surgery 2015 particular paper. Now, question is, this is a model in the bigger number, in the bigger circle. Does it work for us? This model been tried and tested by a different hospital and published later on, based on the Australian figure, particularly, and they've said this 99% of success if we follow the model. So this new model, a new concept, it is a workable solution for any hospital or for our surgeons to try. Now, when you're going to do the PTH level, it is still a matter of controversy, but I follow Australian guideline, and I do particularly 4 hours after surgery and morning after surgery. So that gives me early way of determining when myself going to discharge the patient, because after having total thyroidectomy, mostly or highly likely I put a drain in, and usually drain comes out next morning, depending on the collections. And by this time we have 2 results to support my figure, what I'm going to do next, what supplement this patient will need, depending on the 4 different boxes whether this patient needs to stay back for further testing, further blood testing. That I can decide at a very early stage. The studies have examined a PTH level drawn at a different point of time. The publication I'm talking about in 2017 December, because everybody's looked at this figure and to try to see how that figures works for them, what's the limitation, drawbacks, etc. But it's overall, it says post-op, 4 hours post-op, the predicted accuracy is maintained and allows earlier discharge. And I seen in my own practice, and it has got a very minimal risk of the patient. Of course, in any day, when you discharge patient, we will send them with a note of caution. If they have a symptoms, tingling, numbness, etc., they will come back to A&E straight away, or accident emergency straight away. Some authors argues in this against this model for the routine supplementation. What I mean by that, some surgeons they give calcium supplement as a routine, but that I felt unnecessary, and that is interferes with the calcium hemostasis. But still, that is in a practice that the calcium supplement is given as a routine after hypocalcemia, where we predict preoperatively the risk is very high. For example, with the Graves' disease, for example, with a meticulous level 6 dissection. I don't say it's a black practice, because that gives a very minimal chance of patients of getting any acute symptoms. But I feel that 4 hours post-op PTH calcium can be used as a baseline. What will be my strategy with this patient in terms of calcium supplement? I think that's the best practice in my opinion. Effect of the permanent hypocalcemia, which is very, very important, because why we are talking about that? Because that has got a cost, value, effect on the patient. Again, there's a paper on 2017 which says the clinical profile and the long-term follow-up of 32 patients who needed a long-term or permanent supplement for parathyroid failure. Again, the paper main author is Learn to Poach. It's an endocrinologist from UCL, and they mentioned the permanent hypothyroidism has got significant effect on the patient. Its treatment carry a mild to moderate burden to the illness, to the hospital, to the system. A mean follow-up of nearly 6 years, and only half of the patients suffered a relevant clinical event. So if someone has continued with a calcium supplement, I'm talking about a patient who had a total thyroidectomy and needed a long-term thyroid replacement. If this patient can continue with a supplement religiously, those patients has got very little impact on the quality of life. So two different way of looking at it. Though it's a burden for the system, burden for your practice, but this can have a little impact on the patient if they take the medication as regularly, meticulously, religiously. Now the problem here, because getting this model across the country is not easy, because the variation of practice happens and it's difficult to change practice. There's a guidelines varies from the trust to trust in this country and also country to country, because of lack of consensus on this matter. Different labs has got different variables as a limitation. Not many hospitals have parathyroid test available. So getting the parathyroid level within the day also a challenge. Yes. Sometimes in some hospitals they do those tests as a batch, so they run once a week or something. So which needs a change of practice though. Thank you. And PTH does need some money. In our practice, it takes £120 for each PTH test, so it is costly. But if you do more and more, the cost will come down as well. Coming towards the end of my presentation, so what we learned from here, that Hypocalcemia is not only acute hypocalcemia, which we usually talk about in your exam or in your normal discussion, but hypocalcemia, we need to look at the long-term effect, long-term management. The most important take-home message: doing calcium on its own has got very little value. You need to do a parathyroid hormone level as well and put two things together as a context. I mentioned about a model where you can predict, where you can understand how you can plan your management, which is the clinical outcome of this presentation. We need to talk between us and the endocrinologist of your hospital or you work with, because of many things we do not understand about the hemostasis, the management of the dosing, etc. So we need to have a day-to-day communication with the endocrinologist. Finally, we need to have a national or international consensus about that strategy. And here leaves plenty of opportunity for further audit in your department in case you take these things forward and further research and look into a practice across the world, or if you want to do a prospective research. So here is the end of my presentation. Please unmute yourself, Shivam, and others, Dr. Paul, Dr. Mukherjee. If you have to add more things, I'll be very glad to know from your reactions, what you felt like this is something new to you. Thank you.
Thank you, Mr. Biswas. That was a wonderful presentation. It's not surprising considering he has a diploma in
I can't hear you.
Neither I.
So your voice is not audible, sir. Indranil, sir.
Shivam.
Sir.
I think we request our another moderator, very senior person who is operating thyroid since 1988, Dr. Dipankar Mukherjee. We call him, I call him with my respect, Dipankar da. His opinion about the hypocalcemia, and we should our very senior member and our president, Prasanta, he is also operating a lot of thyroid patients to give the opinion. And I want the opinion of the juniors, what they have seen in their clinical experience. Okay. So please request them to unmute and to share their experience. To ask the question to Dr. Biswas, who presented it so nicely that it reminded me the presentation of Bisha or Ashok of Memorial Sloan Kettering Hospital. Therefore, you presented so lucidly and so beautifully. I'm completely mesmerized by the presentation.
Thank you.
Okay, so now it's the question and answer session. So let them Shivam unmute them and let them ask some questions, and then we can conclude because it is going to be 9 o'clock. We talked in length, say about more than 1 hour. He discussed a small topic. We think it's a very small things. He discussed it in length more than 1 hour, and it's wonderful.
Yes, sir.
Thank you.
It was this actually the most useful and thorough session which we all attended on this hypoparathyroidism after thyroid surgery. So we had lot of queries and most of the queries were solved by your presentation. Means I wrote some questions, but everything is now solved after your thorough presentation.
But if someone wants to ask directly, I do not mind because it's a time to interaction. I can see Indranil back as well.
Number 35.
Yes, sir. Sir, one of our resident, Arpita Biswas. You can, Arpita, you can unmute yourself.
Hello.
Hello.
Yes, sir. Good evening, sir. Sir, actually, I had a bit of confusion at the day 5 follow-up, sir, which you talked about. The day 5 follow-up of the patient.
Yeah.
So when we do the PTH and the calcium, sir.
Yes. So you can go back to my slides. I've already given to Shivam, so you can get the copy of it.
Okay,
So,
sir.
When we have this situation of a hypocalcemia after operation, and then possibly we have to start a supplement. So we like to be 100% sure. So we need to usually review the patient within a week. I say 5 days, practically a week actually, for them to redo the blood. Because we make sure that how much they are taking and for the PTH and calcium level after starting the supplement. So that will be my baseline. When I will look into the case in a month's time or 6 weeks' time, when I'm going to challenge the system to stop the supplement and see what is going on. As I mentioned, in the pH level, at the 5 days, it's very low. Very low means less than 1.6. I will be very cautious of stopping the supplement. If stop supplement at 6 weeks or 4 weeks, chance of developing hypocalcemia is quite significant. So be careful of that model as well. So I give it the strategy, limitation, understanding what you are doing, and a very clear idea.
Okay, sir. Thank you, sir.
Shivam.
Sir.
Hello.
Yes, sir.
Dr. Prasanta was, if you wanted to talk anything. Our president.
No. I like to give my regards and thanks to Dr. Biswas, apart from his schedule, carers, and my sincere thanks to Shivam to arrange this Shoival and of course mental this evening. Dr. Biswas has discussed all the things that we have faced. So, not to elaborate that, Dipankar Mukherjee is here.
Dr. Ghosh, thank you for inviting me and allowing me to talk. I didn't realize I was talking more than an hour. Professor Shah told to go slow and just to make sure that everybody can understand. I apologize for
it's a very
long time.
steady presentation.
Your presentation is extremely nice, and so everybody take its very effort to hear it.
Dr. Mukherjee is there. Dr. Dipankar Mukherjee, any question from Dr. Mukherjee?
Dr. Mukherjee,
well,
yourself.
Hello, am I audible?
You are audible, yeah.
Oh, I'm back. Sorry, I got disconnected because of bad internet connection. I have a question for you. As I was saying that we tend to rely more on serum calcium levels only instead of serum parathyroid and serum calcium levels. And some of us even have to rely only on clinical signs, that is Truchau's and Chostek sign. My question is, how reliable are these signs in monitoring post-operative hypocalcemia? After all, we are going to treat only symptomatic patients.
Personally, in my practice, I'm here for the last 17 years. I've never seen a single patient gone to the stage of that kind of tetany. Never. So patients who are the tingling numbness in the fingers or their lips or feeling tiredness, usually the presentation comes to any symptom. Maybe because of the system is so tight here. Developing to tetanic stage, I have never seen a single patient so far. But it can happen if the patient is far away and there's a delay of taken after discharge, particularly, these things can happen. Patients, when in the hospital and develop this kind of symptoms in the hospital, etc., are unusual and should happen.
Yeah, I was not talking about the tetany. That's an extreme case. I was talking about the Truchot's and Chostek signs. How reliable would you think they are?
They are not part of our clinical practice at all, to rely on the sign, not at all.
Right.
Patient symptoms, as I mentioned, even after operation is with a normal calcium, I'm talking about normal calcium, normal PTH, which can dictate us to repeat the test with the symptoms only. Because as you know, the initial PTH calcium can be normal, but it can fall after a few hours. Particularly calcium can fall after a few hours because when the calcium reserve goes, doesn't happen the patient like a Graves' disease, etc. Those patients, so you need to rely on the biochemical parameters and the patient's symptoms, not the signs. I think I made it clear to you.
Yes, yes. And what kind of success rates do you get with auto transplant? Though the preferred method definitely is to dissect it with the vascular supply. But in case you have a problem
very good point, very good question. So firstly, to come to the preventive part you just mentioned, very short, I mentioned the 2 steps. I mean, the basic, very key to, not the basic, the key 2 steps. One, how to identify the recurrent nerve and do it the right way. Once you see the nerve, second thing you need to see the parathyroid gland, and that helps each other actually. I'll tell you why. There are many methods of identifying recurrent laryngeal nerve, tracheoesophageal groove, there's the right side, left side, etc., etc. But while I'm in a Sloan Kettering hospital in New York, I learned a technique and which I follow as a day-to-day practice. It's still done. If you can feel the cricothyroid joint, which is basically a sharp acute angle, the next time you do the surgery, if you do that practice, I'd be grateful. If you feel the cricothyroid joint, it starts. And if you have a vertical drop from that point 2 centimeter, you think that 2 centimeter nerve has to be there, 100% has to be there, because as you know, the upper part of the nerve is constant rather than the lower part or lateral part. If you have, even I sometimes for my trainees, I use a skin marking pen. I point the cricothyroid joint. I use a paper ruler. I point at 2 centimeters below, and 100% nerve is there, and this is the most constant point. Now, once you get the nerve, superior parathyroid gland, as you know, is superior to the nerve and lateral. And very close to the nerve, is not far. And usually they are attached to the piece of fat the parathyroid gland. So it's good for the parathyroid gland before you start following the nerve forward. Because once you get the gland, the other point is to dissect all the gland that shows. So what I meant by that, when we try to take the parathyroid gland behind or leave the parathyroid gland behind, there is a dissect from midline laterally, and that will help us to preserve all the vascular supply to the gland, not from the lateral to medial. Once you get the nerve sorted, you can see the nerve clearly. The cricothyroid membrane. You find the gland, and now the next part is how to handle the situation. Firstly, I never used any forceps. I always use non-tooth type of variations of forceps that will help better handling of soft tissue, and the dissect from the midline laterally that will help to preserve the parathyroid gland better. If you have to clamp or that posterior, which is the major artery, and usually you get your rectolaryngeal nerve 70% underneath the artery. You try to clamp as close to the gland. If you go very lateral to clamp that artery, then possibly if vascularized without flowing, it's the thyroid gland as well. It is a small technique. The second part of your question, or the main important part, what is the outcome of the re-implantation of the parathyroid gland? These happen in two different scenarios. Where I'm getting mad at not seeing the parathyroid gland. I'm taking fat, etc. and use a bowl of water still to see if they float or not. They float out if they do not reimplant in the in sternum. The technique here, reimplantation, you also need to put a kind of suture which will stay there for a long time, either silk or trolling kind of thing. The reason is if you're dealing with a cancer case and something you reimplant in the sternum, and by mistake is not a parathyroid, rather a metastatic the lymph node, then it's a problem. Do you understand that point? So once you have a post-operative scan, they will show off the technicians scan. They will show off that particular gland within the sternomastoid. In this case, you may need to reopen and remove that bit. So you need to have some sort of identification. Now, your question, how does it work? Nobody knows how does it work. But in a situation where you did not find parathyroid clearly, and then when you re-examine your specimen, attached to the specimen which you removed already, and this is given to you. I think it's always better. This I've seen a surgeon, not present for a surgeon. You may need to visit many times. Or it's not a place to do. So it's important to know how to do it properly as well. Have I made it clear?
Oh yes, yeah, yes.
Dr. Biswas, I'm having two more small doubt.
Yeah.
Robotic thyroidectomy. Can you just elaborate robotic thyroidectomy and this hypoparathyroidism? That is number one. Number two, suppose we are having a palpable node and we are dissecting that node. In that case, level 6 dissection, level 6, nothing is there. Clinically, or while doing the surgery, we didn't see anything. Should we remove level 6, means every tissue in between the two recurrent laryngeal nerve or whatever that area of level 6, should we make it bare to increase the chance of parathyroidism?
Correct. So as I showed my figure before, the highest chance of hypoparathyroidism is around 36% if we have a meticulous level 6 dissection. 36%, highest of all. Only next to is Graves' disease, 32%. So if someone did an absolutely meticulous dissection because he thought there is a metastatic node, chance is high. You need to be careful and you need to know, aware of this fact. And you need to make sure you tell patient beforehand, before operation as well, in my practice, because it's always can create a legal challenge later on. Now the question is two aspects. The current practice, if you on ultrasound scan, not clinically, on the ultrasound scan, there is no visible lymph node, there is no need of doing any neck dissection, because it only increases the morbidity, as you just mentioned, than any benefit of the patient. Because the success rate of thyroid cancer is so high, 90% in 10 years survival. So it's so high, so there's no need. Now, second scenario, you have a lymph node which is visible on the ultrasound scan. I'm not talking clinically. Sometimes you can feel the lymph glands or something, but it's not supported by ultrasound scan. then it will not have any value. I'm talking about before starting the case. So we rely on the ultrasound scan more than the clinical palpation. Now, third situation, you had an ultrasound scan before operation, maybe a few weeks before operation, which was clear of lymph gland, but you opened the neck, you removed the gland, now you see or feel a gland there. Now, if you feel the gland, at least you have to remove the gland for a prognostic purpose. Even you didn't plan for neck dissection before operation, but if you feel the gland, minimal things you need to do about the removal of the gland, because if you have a lymph node positive, then the staging will change, and that probably will lead to radioiodine supplementation for those patients will have a value. So these are three different situations I mentioned with the lymph node in the gland. To summarize, if there's no lymph gland clinically or ultrasound scan, no need of doing any neck dissection, zero. Secondly, if you have an ultrasound scan showed a lymph gland, whether you can feel clinically or not, doesn't matter, you should do a neck dissection. Usually level 6, usually not lateral, if according to the findings of the ultrasound scan. Thirdly, third situation, ultrasound scan before operation was clear, negative, but on the table, you feel something there, then you need to act on it. You cannot leave that behind completely, even if you did not take consent from the patient, because that will change the management, as I mentioned, with the radioactive iodine, etc., post-operative plan. Now, Professor Shah, you have a next early part of the question about the robotic surgery. I do have a very limited experience. I worked with someone called Patrick Aiden in France, in Paris. He does only robotic surgery, nothing else in his career now. So he's got a very high volume robotics thyroid practice, and he learned those techniques from the Korean group, the Park, that group, and he given me opportunity to stay with him and to learn the technique. To be honest, when I came back, I felt like it's too much cumbersome and not to do with robotic surgery than doing a standard practice. Only indication, in my opinion, for robotic surgeries are if someone is celebrity, who does not want any scar in front of the neck, and like newsreader, actress, etc. Those are the only indications. However, as you know, the Patrick Aiden, I spent time with him in an American hospital in Paris. He has a big practice. He does 2, 3, 4 a week in each session, a whole day session. So in his hand, hypocalcaemia rate is not any higher than normal operation, because of a resolution of doing the surgery is very high. And also to say, it depends on the practice, because he's doing it for last, say, 5 years. He has got a different learning curve. In his hand, the time of the operation and also the complication rate is no way higher than a normal standard practice. I do not know whether you are bringing your robotics in the thyroid practice or not, but in the NHS it's not popular because the money matters, because of the outcome matters. We could not justify to use robotics over the standard practice to give a better benefit for the patient. Is it clear enough, Professor Shah?
It's fine, Devo. It's fine, and it clarifies all the doubts. So anybody else, then Shivam, you can conclude the session. Shivam and Indranil, you can conclude the session, yes, because it is going to be dinner time and almost 9 o'clock here.
Sir.
Okay.
Sir, one last thing. Yeah. Sir.
We must thank Dr. Biswas for the wonderful presentation and clearing up all the doubts. And anybody is having any doubt, please clear it right now. Okay.
So one thing I want to to ask you, sir. While we save the arterial supply to parathyroids, we search for the inferior thyroid artery supply to parathyroid to save it. Do you recommend the use of microscope or loop during that dissection to save the vascular supply of parathyroids, inferior, basically?
In my practice, I do not do any operation without loops, the thyroid operation. So all operation under loops. So, 6 times a medication, I use my loops, and that is what the practice I do every case. So if you use loops for one case, you don't use for other cases. This is don't get the expansion every day. So yes, the answer is I recommend the microscope because it's much easier to handle the situation. You can move your head, the loops going with you. You can have a light on the loops as well. So you have a difficult angle to see. So this is the best.
Thank you.
So we call it a day. It's a hectic day. He is on call again. Okay. So
Thank you. Thank you for.
But in future, if there is any need, you can take a class for our PG and all these things. I was having that idea for quite a long time for all this because you are not only a thyroid surgeon, you do a lot of other head neck. You can talk about the tongue and other things. Any day, if you have any time, please do guide us in this time.
Professor Shah, you have guided me a lot in my early days. I will always like to return it back as soon as I can. Also to mention that I have another program organized by myself on 30th of September, which is a study day for thyroid cancer. 6 speakers for the section, which will be run by this hospital, my hospital. Like your platform, I haven't decided which platform to take. Shivam, I'm not as good as you. I'm sorry. And also I've been limited by my trust because they will tell us which platform to use as well because some platform is not secure because of clinical photographs, etc. So we haven't come to that point yet. Shivam, I'll give you the details for you to pass over to your trainees and the friends and the other seniors if you want to join us. The program is 2 o'clock start. That means your time will be 6:30 p.m. I think it's a good time. That's a Wednesday evening, 30th of September.
That will be great, sir. That will be great thing for us to attend.
Thank you. It's nice to see you all, and particularly Shivam, Professor Shah. I did not see Shoibal at all, or Dr. Shoibal, maybe he is there somewhere. And thank you, Dr. Pal, Dr. Mukherjee, for having me.
Thank you.
Thank you, doctor, for your time and the guidance that you gave us today. Thank you.
Thank you very much. Bye-bye.
Sir, bye.